Hi, and welcome to Vetsplanation. I'm your veterinary host, Dr. Sugarman, and I'm going to teach you about veterinary medicine. In this podcast, we can dive deeper into the understanding of what our pets are going through and break down medical terms into easier to understand chunks of information. Just a quick disclaimer, this podcast is for informational purposes only. This is not meant to be a diagnosis for your pet. If you have questions about diagnostics or treatment options, please talk to your veterinarian about those things. Remember, we are all practicing veterinary medicine, and medicine is not an exact science. Your veterinarian may have different treatment options and different opinions. The information I provide here is to help pet parents have a better understanding about their pets. If you like our podcast, please consider sharing this podcast with at least one friend or just somebody else who has pets as well. Now, let's jump into this week's episode. Hi, everybody. Welcome back to the podcast. Welcome back to Vetsplanation. I'm your host, Dr. Sugarman. And again, we're going to have Dr. Z here. You might have remembered her from the diabetes talk. So I really appreciate you coming back on again today.
My pleasure. Happy to be here again.
Yeah. So we're going to be talking about Addison's disease today. So I have talked about it on podcasts before, but very much on the emergency side. And Z is my go-to for all things general practice. So a lot of times I fix them for the immediate portion and then I have to send them over to her to do all the other stuff.
Let's take it over.
Yeah,
Yes,
exactly.
No problem.
All right. So she's going to talk to us about Addison's disease today.
Yes, Addison's disease. What is it? It's an endocrine disease, which means it's a hormonal disease. There's lots of different hormones in our bodies, and hormones are basically messengers that tell one thing to do another thing. And usually there's a gland somewhere that secretes the hormone and another gland somewhere else that picks it up and then does something with it and secretes another hormone.
Yeah.
So there's always these loops of talking to each other. So Addison's is actually hypoadrenocorticism, hypo meaning too low, and then adreno referring to the adrenal gland. And corticism is the cortex or the outside of the adrenal glands, which is where the hormones that we're talking about are being produced. But it's just easier to say Addison's and
It's
then
less of a mouthful.
Yes, it's like Addison's disease, much easier. I actually was wondering where that name came from, because there's always like some dude or dudette the disease is named after. And I actually found out about Thomas Addison. He was an English physician for humans, and he lived in the 1800s. Mm-hmm. And he liked to do autopsies on dead people. Like he would just cut them open and look at things and try to learn about them. And he was very interested in the adrenal glands, and he found that people would die from the same symptoms, and then they tended to have the same problems with their adrenal glands looking small or whatever.
Yeah.
So he figured that out, and he did a lot of other work too. Like he figured out pneumonia, the pathology of pneumonia. So he's pretty famous. So that's Addison's. Yeah, that's why it's called Addison's, because he figured it out. So what's happening with that disease is the outside of the adrenal glands, which maybe I should talk about where they are.
Where do they live? Yeah.
They are these little glands that live above our kidneys, or towards our head, cranial, as we would say, cranial to the kidneys. If you imagine a little triangle, like a equilateral triangle with even sides, and then smush it a little bit and round the edges, that's what the adrenal glands look like. And they're normally pretty small. And they have this outer layer and then an inner layer. And the outer layer is where these specific hormones are made. So there's actually 3 of them. And I was actually listening to your previous podcast, and I was reminded about the salts.
Salt, sugar,
and sex. Yeah. So the salt part is what we call the mineralocorticoids. I have such a hard time saying that.
Another mouthful. I think it's just a lot of mouthfuls.
Yes.
Yeah.
But that one, I can't get around it. I'm going to have to say it over and over. So that one balances our electrolytes, our salts, basically helps with many things, which I'll go into in a second. And then the other big hormone there, the sugar one, is the glucocorticoids, which is also known as cortisol, or it's just another steroid that helps do many things, which I'll go into in a second. And then the last one is like some androgens, some sex hormones are produced there too. But that's not the only spot, obviously, that those are made. Right. That we have our ovaries and our testicles where the majority of the sex hormones are produced. And that doesn't seem to be as affected in general, probably because it's in other places as well. And we really just don't worry about it in dogs and cats because we're mostly neutering them anyway.
Right.
So really, we're just talking about the glucocorticoids and the mineralocorticoids. And when you have Addison's disease, there's a deficiency in those hormones. They're not being produced anymore. And so all kinds of problems happen when you don't have them. So let's talk about the glucocorticoids.
Yeah.
They basically, in summary, help us deal with everyday stresses. And they do that by telling our liver to produce glucose and give us energy. So glucose, as I talked about in our diabetes lecture, is the smallest molecule of sugar that's used to make us have energy, basically function. And all of our cells need it to work. If we don't have those glucocorticoids telling us to make it, then all kinds of bad things happen. Glucocorticoids help us move our fat and our protein to, again, produce energy. They talk to our blood vessels, actually, to help us respond to stresses. And they help regulate our body temperature and our blood pressure. And it helps our stomach maintain a mucosal barrier so that we don't get ulcers and digest our own stomach.
Yeah, I actually didn't know that. So it was very interesting to read about that.
Yeah, glucocorticoids have a ton of functions. And they're involved in many metabolic functions besides that, too. It's a very important hormone that we need every day. The mineralocorticoids help us, again, regulate our electrolytes. And so the big ones that are working for us to maintain our fluid and our blood volumes are potassium and sodium. And that if we don't have the right levels of those, then again, our blood pressures are off, our muscles aren't working, the heart isn't working right. The heart is very responsive to potassium levels. Our gut needs our sodium and potassium to work properly. And then our brain, of course, needs it too. When we have those sodium and potassium levels going out of whack, it's very dangerous and life-threatening. Mm-hmm. Okay, so I wanted to talk about the normal physiology of how these hormones are circulating in our body and making all these things happen. It's what I call a negative feedback loop in general. So if you were to think of like your thermostat in your house, say it's wintertime and you have it set to heat the house. If it drops below, 66 degrees or something, it's made to detect the temperature, right? So that's what it's detecting. And if the temperature falls below that 60 whatever, then it talks to the furnace and says, turn on and start heating the house. And so then the furnace turns on, starts heating the house, and that thermostat is then feeling the temperature go up. And when it hits 70 or whatever you want it, it'll say, oh, that's where I want to be. And then it tells the furnace to turn off. And it's like this constant loop talking to itself. Constantly adjusting and tweaking things to keep things balanced in the temperature where you want. So that's how all of these hormones work. And it's really important that we understand that to figure out what's happening with Addison's disease. So in the loop, you got to start somewhere. So I'll just start in the brain.
Okay. Important part.
Yes. There's kind of two parts in the brain that are in this loop. And it starts in the hypothalamus, which is a part of the brain. It secretes, when we don't have enough glucocorticoids and mineralocorticoids, just like the temperature is too low, right? This is what it detects. Oh, I need more of that. Right. So it secretes a hormone called the corticotropin releasing hormone, so CRH, which we don't really talk about that much. It's like a small signal, but it's important. And that goes to the pituitary gland, which is just a little bit lower in the brain. And the pituitary gland has many different hormones functioning out. It's like a hot center for hormones.
Yes.
It has many different functions and talks to many. It's like the, I don't know. What am I trying to say? Like the central.
Yeah. I feel like it's
Houston talking to the spaceship.
Exactly. I was thinking also like your Google Nest talks, like you can have it talk to your lights. You can have it talk to your garage. You can talk to all sorts of things.
Yeah. The main center. So anyway, the pituitary then is like, oh, now the hypothalamus is telling me that we need more glucocorticoids or mineralocorticoids. So it squirts out ACTH, which is adrenocorticotropin hormone. And that's also a mouthful, so we just say ACTH. Yes. That's what it is. And it's coming from the pituitary gland. And that then goes and talks to the adrenal glands and just the outside part of the adrenal glands. And it tells them, okay, time to release mineralocorticoids and glucocorticoids because the boss says we need more.
Time to turn the heat on, essentially.
Yes, let's turn the heat on. It's like the furnace, right? Turn on. The adrenal glands do a little squeeze, and those mineralocorticoids and glucocorticoids are released.
And released into the bloodstream.
Into the
right?
bloodstream, yep.
Yeah.
And then they can start doing all of their lovely functions to deal with stress and keep our lights where they need to be. And then when there's too much, then it turns back off and just circles around again and again. Also, a little fact is the ACTH actually keeps that cortex the right size. So if you don't have ACTH, like there's a lack of it, those adrenal glands will start to shrink.
Yeah.
And you can actually measure those and figure that out with an ultrasound.
Yeah. I will say it, they are hard to find.
Yeah, they're
pretty
tiny to
small.
begin with.
Yeah.
And then if they're not working, they're really small.
Really tiny. Yeah.
Yeah. So yeah, it influences the size of the adrenal gland. Yeah. I think that's the whole physiology.
It's a lot, right? But
It is.
it's such an important thing that happens inside of our body.
Yeah, it's unbelievable, all the messages that are happening constantly to keep us going,
right?
In many different ways with all of our organs and everything.
Yeah.
I love it.
So now we've kind of like talked about like, a little bit about Addison's and the adrenal glands and stuff. Are there different types of Addison's disease?
Yeah, and you talked about them too. There's just the main two that we talk about mostly, but there's actually 3 types, and I'll go through it. There's the typical Addison's disease, which is the most common, and that's what we normally deal with. And that's when the entire adrenal cortex is faulty. So both mineralocorticoids and glucocorticoids are not being produced. And I think it's like an autoimmune cause, like as far as why does this happen, we're not sure. Like a lot of these diseases, but it seems to be the body starts to attack its own adrenal glands and then they just stop.
Yeah.
So that's the most common. And then there's atypical, which is where only the very outermost part, I think, is where the glucocorticoids are produced. That's where just that part is not working. So we don't have glucocorticoids, but we still have mineralocorticoids. So all of those electrolyte disturbances are not happening, but we just don't have the glucocorticoids and can't deal with stress. That's a little bit harder to diagnose because oftentimes we use those lights as a big red flag.
Right.
As when we're trying to diagnose what's wrong. Usually it's, those lights are wrong, must be Addison's, let's test for that.
Yeah.
So it's a little trickier when it's just the atypical, but you can still figure it out with step by step.
Yeah.
And then there's what we call secondary Addison's, which is hard to understand because maybe that's also atypical. Anyway, secondary is very rare. That's when the pituitary gland isn't working. Like
so that's the gland in your head.
Yeah, the brain tumor, like it has affected the pituitary or somehow. Or there can be a weird infection that gets there or something like that. Also, it can happen when steroids are taken away too quickly. Say you're giving steroids as a treatment to a patient, and then instead of tapering it off slowly like you're supposed to, you're giving high doses and then suddenly you just stop it. And what's happened is like all those steroids have suppressed the ACTH normally from happening. And again, that makes our adrenal glands stay the right size. And so when you don't have ACTH, it just shrinks down and atrophies. And so then when you take away the steroids, we can't produce our own anymore. It's just been taken away and then we can't make any. And then we start falling into Addison. So it's rare because usually we're pretty good about tapering, I think, steroids. I don't see that often. And honestly, I don't know if that's something that would eventually get better. Seems like it probably would.
I feel like it should eventually, like your heater should kick on, right?
Yeah. And it gets cold enough for long enough.
Exactly. Yeah. I guess it's hard to know. I haven't really seen any that's been a secondary one.
Yeah.
So I don't know for sure.
Again, it's super rare.
Yeah.
I just was reading about it.
Yeah.
I mentioned it, but definitely we deal with normal, typical Addison's the most where we don't have both mineralocorticoid or glucocorticoid.
And then now that we've kind of like talked about what the types of them, are there differences in what the symptoms of everything are?
Yeah, so the symptoms of Addison's are very vague, and I think you talked about that too. And it's probably one of the hardest things you deal with in the ER is there's no one symptom that you're like, yes, this is Addison. It's often called the great pretender because it affects so many systems, as we talked about all the different places that these hormones work. So GI is a big one, vomiting and diarrhea, bloody stools, belly pain, dehydration. It can also cause increased thirst and increased urination, which we'll see with many different diseases, including diabetes, like we talked about, kidney disease.
Urinary tract infections, like
UTIs.
so many things.
Yeah. So it's like super not specific.
Yeah.
A lot of times they're just weak and losing weight. And as it progresses and turns into the crisis, it gets much more dramatic. Like they'll collapse and their heart will slow down and their blood pressure drops and they're like in shock. And that's the Addisonian crisis when they've not had those hormones for too long and they can die. It's an emergency for sure.
Right.
And that's probably how you've seen them.
Yes,
occasionally.
exactly. That's the majority of when I see them is usually in crisis at that point. Because the interesting thing is also it's, these very intermittent signs. It's like they have this vomiting and diarrhea and then they get better without really anybody doing anything. And then they come back again. And then
something like they'll come in and you're like, oh, let's treat for your GI symptoms. Let's give you some fluids and let's give you some anti-nausea meds and here's some diarrhea medicine. And that helps.
Yeah.
And then sometimes maybe you give a steroid for whatever, a shot of Dex. Oh, maybe this is an allergic reaction. Here's some steroids. And that helps them so much because that's what they needed.
That's what they needed, right? Exactly.
So if they have that waxing and waning history and then suddenly it just gets super bad one day and then you run the full diagnostic blood work and then you can figure, oh, this actually is Addison.
Yeah. Since you're talking about this now, how do we diagnose it?
Yeah. Blood work is how you end up in a nutshell diagnosing it, but let's go through it. And you did a bit on yours too. I was listening. But so the CBC is the complete blood cell count. You'll see what we call a lack of a stress leukogram. So these patients are usually stressed out. Just coming to the hospital is enough to make a dog or a cat, or cats don't get this, but to make a dog stressed out. So usually we'll see certain levels of white blood cells that indicate stress, like their neutrophils will be up, their lymphocytes will be down, those sort of things. And you don't see that. So there's normal looking blood cell counts, or maybe those lymphocytes are a little bit up, which is weird for a stressed dog.
Right.
So there's that. And then sometimes that's all you see when it's an atypical Addison's dog, right? Because then on the chemistry panel, you have your electrolytes on there. And, the typical Addison's dog will have a very high potassium and kind of a lowish sodium. And then the ratio between the two is decreased. So that's what we talk about mainly is the sodium to potassium ratio. Because sometimes you can have a lowish sodium potassium ratio and they're not Addisonian. But if the potassium is actually high, like above the normal range, then that's a big red flag.
Right.
And so then the next test you would run would be called a baseline cortisol test. And so that's looking at cortisol levels, right? Those glucocorticoids.
Right.
And if it's normal, 5 or something, then you're like, okay, it's not Addison's, because it couldn't be. Like if they had Addison's, they're not going to have any cortisol.
Right.
So it's baseline cortisol is super helpful to just rule it out, but it doesn't rule it in. Say it's low, then you're like, okay, I think it is Addison's. Everything's adding up, but you have to do one more thing. You have to do what's called the ACTH stimulation test to confirm that it's Addison's. And so we have fake ACTH. It's called cortisol. That's the hormone that's produced in the pituitary gland. And we can give an injection of it to the dog and then test their cortisol level after that. And
see how it's responding. See if that furnace is turning on, essentially.
Yeah.
Yeah.
You like my analogy.
I do like your analogy. Yeah.
Yeah. So you have your baseline cortisol is really low, and then you give them some cortisol. An hour later, you check the cortisol level again with the second blood draw. And then if it's still low, like usually it's super like undetectable, it's 0.2 or less on an Addison dog. And if it's still that same number or you can't detect it after the cortisol shot, then they're definitely Addisonian.
Yeah.
And this is the one good thing about this disease is that's how you can diagnose it for sure. Like it's your gold standard for diagnosing this disease.
Yeah, which is really nice because we have that in-house. There's so many things that we have to send out, or we have to just rule things out in order to get to that disease. But this is such a nice one because you can.
I love it.
We have an in-house test to do that.
Yep, we have the ACTH or the cortisol, and we can just do those stim tests as we'd like. Yep.
Nice.
Yeah, and there's other like diagnostics that you can do too that can help us figure out like their blood pressure will be low and. If you do that ultrasound, you can see atrophied or very tiny adrenal gland. And then on the urinalysis, not much there, except maybe it's dilute urine. When the electrolytes are out of whack, it can actually wash out those kidneys and then they can't concentrate their pee anymore. And that's what makes them thirsty. And so it's a different way of causing that symptom in this disease. But yeah, that's how you get your increased thirst and increased urination is because those electrolytes are not normal. Yeah. But really the kicker is that ACTH stim test, and you need blood work to diagnose it. Yeah.
And, you're talking about like the baseline cortisol, and I do think that's also a hard one too, because we don't always run that if we're just seeing some of those other signs, just vomiting, diarrhea. But
Yeah.
when we start seeing all of that blood work, it's so hard to diagnose those atypical ones, like you said.
Yeah.
We don't always run it because we don't always think about this disease.
And then the cortisol would be normal, and you'd be like, man, it's not Addison's.
Exactly.
But it might be.
It could be. Yes, exactly.
So I think it takes a little bit of time on those because like they'll come back again and again.
Exactly.
And you're like, oh, maybe this is, and then you can do a stim test and maybe it'll be negative, but maybe it'll be positive. You'll be like, oh, that's
just don't know. And I know there's also a gray zone to this as well. So I've had to test Nora, my Great Dane, for it because she would not eat intermittently and have intermittent vomiting and diarrhea.
Yeah.
And hers was like 2.5, this perfect gray zone.
Oh.
And it was like, it could be, could not be. We just have to retest it later.
Yeah.
So sometimes we do have to do that too. But
I think sometimes it's like getting worse over time too. It's like progressing.
Exactly.
And I just realized I misspoke. I think the baseline cortisol would be low on the
it usually is low on the atypical still.
Yeah. It's the lights that would be normal. So that's why you're like, I don't think it is. But yeah. But then you check your baseline cortisol and it's low, and that could trigger you doing the stim test. Yeah.
Right.
But there is a gray zone. Yeah. Because usually if it's Addison's, it's really low. I was going to talk about the breeds, but there's so many of them. The list just went on and on and on. And then honestly, I've seen it in so many like other breeds that aren't on the list that I just want to say many and any breed. Yeah. Really.
Yeah. I don't think there's any breed that cannot get it. So when do we typically, what ages and stuff we usually diagnose them?
Oh, any age. There's the juvenile onset ones as young as 3 months, even 2 months. Yeah, and then they can be much older too, like later in life, get it 13 years old. Right. But usually it's in the middle, I'm going to say.
Yeah, I think that in school for like our testing, I think they said there was 2 peaks to it, like somewhere around 2 years old and again somewhere around 10 years old or something like that.
Okay.
At least that's what they asked us to remember for vet school. But I feel like it could be anytime.
Anytime. The little bit of reading I was doing was saying the mean is 3 to 4 years, or the median, typically the young to middle-aged.
Yeah.
But yeah, really it's kind of across the board.
Right. Okay. And like I said, so many different types of dogs that get it, right? Do cats get it as well?
No, it seems like it's a dog-only thing, although I'm not sure. Did you look it up?
I have looked it up before, and they have like cases that they think of cats that might have had it before.
Okay.
But it's not like a widely known thing that cats usually get.
I've never seen it. Honestly, I haven't really looked for it, though.
Yeah. But neither do I.
Seems to be not a thing for them.
Exactly. Yeah. And even then, I don't think you can run our in-house test for it. I think you have to send something out for them instead, if I remember correctly. I'll have to look that up.
Okay.
But I think that's what I remember. But now that we've diagnosed this, so how do we manage them?
Good. Managing where I come in after you've saved them. And then I see them usually like a month later. And there's 2 treatments that we start and need to continue for the rest of the dog's life. The first one is replacing the mineralocorticoids. And that's an injection. It's called Zycortal, or DOCP, which stands for desoxycorticosterone.
I'm impressed you could say that. I couldn't say
I practiced. But yeah, we just say DOCP, and there's this off brand now called Zycortal that's a little bit cheaper, so we usually just call them Zycortal injection. And it lasts for about a month, and we usually have to start at a higher dose when they're first diagnosed, and then we can slowly taper it down to about 50% of that starting dose. And it usually takes 4 to 6 months to get there. I taper it about 25% each month if their lights continue to look good. So first I check their lights. The sodium-to-potassium ratio is above 25. 25 is bad. In the 30s is better.
Okay.
But I want them to be like in the 30s and not at 25 or near that. Then I think it's working well, and we can decrease by 25%. And it depends on the dog's weight too, which can fluctuate. So I'm always like calculating it. And then we check again in another month, check the lights. If we're still doing okay, keep going down. So usually about 4 months down the road, we can get down to the final dose. Okay. And then we also have to replace those glucocorticoids. Right. So the easiest way to do that is just give a steroid. Prednisone is the one that we typically use for dogs. And we have to be careful with that, because if you give too much, then you can get bad side effects. just taking steroids can be problematic. The biggest thing is it can cause increased thirst and urination.
Still stuck with that.
Yeah. And for different reasons, though, but they're peeing a lot, and owners are complaining that they're having accidents in the house and they're super thirsty. It makes them hungry, so they're stealing the trash and they're gaining weight. And then if you keep it up, they start to lose muscle, usually on their head. They'll get pred head.
Pred head.
See the bones stick out on their head. It's sad. You can avoid all that if you are very conservative with that dose of prednisone. They hardly need any. Like the natural body produces just a tiny bit.
Yeah.
And so honestly, I just use the dog's clinical signs to tell me what the dose will finally be. And we talk about it at every visit when we're tapering that Zycortal dose. I'm like, okay, how's his thirst? How's his urination?
Right.
Is he eating a lot still? A lot of them are like, he's just panting all the time. That's another thing. It's like panting. And that usually all gets better as we get down to that final dose. And I found that you guys actually sent them home a little too high about most of the time. I know you're being cautious because they were dying.
Because they were dying, right, exactly. So we do a little bit of a higher dose.
Yeah. Yes. And I'm always like, oh, look at this pred head. We need to give one.
They do it, like, get that just in a month?
It seems like it. The last one I saw he was a pointer. He was an old pointer, though. So I think
maybe it's just a mixture of things.
Losing muscle anyway. But yes, he definitely had too much. And so I'm getting way back on that.
Yeah.
And then if it's a small dog, we usually end up, it's hard to cut those pills, especially the oblong prednisones.
Right. Yeah, it's real weird.
Quarter is even hard. So I usually switch them to the liquid. There's one they make for kids. It's 3 mg per mil.
Oh, nice.
Suspension. It's really cheap and easy to get at any pharmacy.
Yeah, great.
So I just write them a script for that and tell them how many mils, 0.5 mils or whatever to give every day. So yeah, but I put a lot of the smaller dogs on that because you can really get down to a nice, accurate low dose.
Yeah.
And then that's it really, is just keeping them on those 2 medications. The Zycortal, I will say, sometimes their lights aren't good when I do the recheck. And so you can do 2 things. You can give the Zycortal shot more frequently, like instead of 28 days, give it every 25 days. But that's hard for the owner to count and make that appointment. So I usually try to just keep it at once a month and just go back up with the dose. That's the other thing you can do, is just give a little bit bigger injection.
Yeah.
And so we're careful with that in the beginning and checking those lights, and then I can help them with that plan when I look at those numbers. But pretty much all of them seem to be just fine with a smaller dose. Like,
good.
I don't think there was one, that dog had gained weight, I think. So they needed a little bit more.
Got it.
So I went back up, but that was like years later.
Yeah.
That's why we have to keep checking.
Right. Exactly. Right.
So that's the other thing. Once we get to the final dose, then it's every 6 months. I like to do a full checkup, exam, check their weight, talk about everything. And once a year, I like to run full blood work, and senior panel-y stuff. And then every 6 months, alternating just plain electrolytes if they're otherwise doing okay. Lights every 6 months, full blood work once a year.
So just to clarify, because they're still coming in each month to get their DOCP injections or Zycortal injections. Just now we have a dose that we know that they're going to get.
Yes. So once that plan is established, then it can be technician appointments for those Zycortal shots. They have concerns, they can schedule an exam again, but usually it's just a quick poke. And then also on that last visit, if the owner is comfortable and interested, I can show them how to give the Zycortal shots, and we can sell them the whole vial, and they can just start doing their shots at home.
Awesome.
They don't have to even bring the dog in.
Yeah.
But every 6 months.
6 months. Right.
So some people are comfortable, some are not, and some are happy to bring the dog in once a month. So whatever they want to do.
And that's for typical Addisons. So for atypical Addisons, we're not doing the injections, correct?
So it was interesting because there was one that was recently diagnosed that I took over, and they had given DOCP, even though it was atypical. And so I just went with that and kept giving it.
Okay.
And that's because actually a lot of these atypical ones will eventually become typical.
Oh.
I think, there was a study, not all of them, some will stay atypical forever, but it seemed like there was a significant portion of dogs in the study that eventually turned into typical.
Interesting.
Addison. So to just avoid having that whole crisis, even just give the Zycortal every month.
Okay.
So
that's good to know.
In that case, I just kept going with it because they'd already started doing it.
Right.
His lights were normal.
Oh, good.
I don't know if it's from the DOCP or
we're just normal. Yeah.
It was normal anyway.
But if it was, let's say with the DOCP, obviously it doesn't have any harmful effects then.
Nope. It's just like doing nothing then if they already have it. Yeah. You can't overdose with that medication. Yeah.
Nice. When they are just on pred, though, do you still have them come back for rechecks?
That's a good question. I don't think I've ever had. They're so few and far between. Honestly, I haven't managed a lot of atypical ones. I guess I would be worried about them turning into typical. And I would say at least every 6 months.
I think also you were mentioning before about coming in after a month. After we've diagnosed them, usually at the ER, you're having them come in a month. I think that's also still important for them to do, even if they're atypical, because at least then you can adjust the pred dose so lower.
Yeah.
Then we sent them home with.
Yeah. So probably the initial 1 month checkup, even for an atypical, is needed. And then you can go from there. Yeah.
I think you kind of touched on this too. How do we know that the medication is working?
Yeah. Basically, all those symptoms go away. So they're not vomiting and having diarrhea anymore. Their lights are normal on the rechecks, and they're just like a normal dog again.
Nice. Which is what we love. And then is there anything that the pet parents should do like when they are in times of high stress? Because I know we need more glucose during times of high stress.
Yes. Yeah. And you talked about that too. You said you give a double dose the day before, the day of the stress, and then the day after. Honestly, I think they only need it the day of.
Oh, really?
Yeah.
Okay.
But there's no right or wrong with it.
Yeah.
I don't think they're going to go into crisis that quickly.
Okay.
Again. And again, I just see so much overdoing with the prednisone that I'm always like, no, just give it double dose on the stressful day. That's all you need.
Okay. Yeah, I think we're just like so overly cautious. We're just like, we don't want it to come back in crisis. So
yeah, I try to just make it easy for the owner too, because then they might forget. Oh no, I messed up, and it's okay. Just give another dose, extra dose. So double dose either can be give double that once a day, like instead of half a tab, you give a full tab that day, or you can give a half tab in the morning and a half tab it.
Okay,
it doesn't really matter.
Okay,
as long as you give it double.
Nice, perfect. Yeah. And then does this diagnosis like really decrease the pet's lifespan at all?
No, it's an excellent prognosis. Once you get it figured out and keep managing and monitoring, they have a normal lifespan and are like a normal dog again.
Yeah.
So it's an excellent prognosis.
Yeah. I do love this disease because, like I said, it's sometimes we have this great, easy way to be able to diagnose them, and then it's not like we're going to cut their lifespan.
No, not at all. Thank goodness. Yeah. It's one of those treatable diseases. The hard part is keep going with the treatments, and it can be a little expensive. I actually looked it up on our computer trying to figure out how much does it cost for a 100-pound dog. The Zycortal is the expensive part. Prednisone's dirt cheap.
Like, so cheap.
Yeah, that's no problem.
Cheap,
but the Zycortal injections are expensive, and it's priced by volume of the injections. That's another reason why we taper it, because it gets cheaper as you give less of it. So if you have a big dog, though, like I had a Great Dane Addisonian dog, and his shots was like $200 every month because it just weighs so much. But usually the first shot for a 100-pound dog is going to be around $300, and then hopefully we can taper it down to about $165-ish long term. And then for comparison, a 10-pound dog, like a little terrier or something, it's about $60 initially, and then hopefully we can taper it down to about $40 once a month. So smaller dogs is a lot cheaper.
Yeah.
And then you have every 6 months, you got your exams, which $100 now for an exam. And then the blood work, a couple $100 for full lab work. And then lights are what, $80?
So they're like $80? Yeah,
something like that.
Yeah.
So it adds up, but at least that's only every 6 months. It's really just the monthly Zycortal that's the biggest expense. And I think mostly for the bigger dogs. We already talked about side symptoms coming back. Actually, it can be, again, vague. Because we weren't sure what the symptoms were to begin with. But it's possible for an Addisonian dog that's well-regulated to eat some bad turkey and have
get in the trash can.
GI side effects from something else, not his Addison's. I think the important thing is especially if you go to a different vet, that's because your regular vet isn't open or whatever, tell them that your dog is Addisonian and tell them when they had their last DOCP shot.
Yeah.
So that they're aware of that problem and can rule out that recurring or not being well regulated.
Yeah. But I do appreciate when people tell us that, like when they come into the ER, because that's a really, I might be talking to them about something completely different until I know that they have Addison's disease. And I'm like, oh, we need to recheck your blood work.
Yes.
So,
yeah.
Was there anything you wanted to add to this?
I don't think so. Just that I think it's one of the better diseases out there. Like hypothyroidism, I like that one too, because you can totally fix it.
Great. You're going to talk about that on another podcast, because that
one's kind of boring.
Mine.
Okay, You never have it.
I never have that.
Hypothyroid.
Exactly. So, so last time I had asked you about like your favorite animals. So
Oh, yes.
this time I'm going to ask you, why did you decide to become a veterinarian?
I think I'm lucky in that I'm one of those people, like ever since I was little, that's what I wanted to do. First thing I remember having kittens at home, I want to be a veterinarian forever. What do I want to do? It was either that or an astronaut. I really think that outer
Nice.
space is amazing.
Yep.
Blows my mind. But I get seasick really easy. Like
Oh, that
motion
might be a
sickness.
problem. Yeah.
So I'm like, no, okay, it's a vet. I'll be a
Right.
vet.
So you don't go on many boats, I'm assuming.
No, it's hard. I want to, but
Right.
it sucks being seasick.
Yep. Yep. Exactly. Can't really enjoy it.
No.
Yeah. So did you go to school like directly like to become a veterinarian? Like
Yeah, to New Mexico State. And it's a big ag school, so they had a lot of fun classes there was a horse class. I thought I wanted to be a horse vet, actually.
Oh, wow.
Yeah. Until I went to vet school.
And then you're like, no.
Never mind.
Yeah.
Dog and cats are better. But yeah, so there was a lot of animals there. And I started out with animal science as my major. And then it got a little too farmy. There's a lot of like cowboys and stuff there. And it was just a little bit, I don't like country music, It's like,
Same here. I understand.
it's
Yes.
just a thing. And so then I switched to biology and majored in that.
Yeah.
And then I got into vet school. And yeah, it was like always my goal is to get into vet school.
Nice.
When I got into Oregon State. And
No, I didn't even went to Oregon. I just kind of assumed you went to Washington.
they only had a large animal hospital at the time, back in the day.
Yeah.
And so they had this program with Washington State. So we would go up to Washington State for a year and a half. We were there doing small animal stuff. And then we had to go back to Oregon State. So there's a lot of moving.
Yeah.
Kind of sucked, but
Yeah,
but yeah, I actually have a diploma from both schools.
That's so crazy.
Kind of cool. Yeah.
Oh, funny.
But I applied for both schools because I would rather have just gone to Washington State because they have a 4-year program there.
Right.
But,
in small animal.
Yeah.
Right.
Mm-hmm.
Yeah.
But they declined me, so I'm a beef at heart, man. Yeah. Anyway.
All right. Well, cool. Thank you, Dr. Z. Again, I super appreciate it, and I know we're going to be talking about, I think, Cushing's disease next time that you're going to be on.
Okay. Yes. I'm sorry I didn't get it together today.
No. This is already going to be a long enough episode, and Cushing's disease is just a whole
another topic. Yeah.
Yep, exactly.
Less of an emergency, but there's some good stuff to talk about.
Which is definitely why I want you to talk.
Okay. Thank you so much again.
Thank you.
Yeah.
Thank you guys for listening this week. If you have any questions, comments, suggestions, or you just want to say hi, you can email me at shugs, SUGGS, at vetsplanationpodcast.com, or visit the website at vetsplanationpodcast.com, or find us on Facebook, Instagram, or TikTok at Vetsplanation. Thank you all for listening, and I'll see you back here next week.